OKU card did not mention, but the mentions use the YCAN. Standard body checkup not mentions, and no current medication or supplement list, and also not written for drug or food allergic, not stated. For next, okay, patient task-related history summary. In mobility, patient mentioned that using the YCAN for the unfamiliar place and while not using the YCAN in the familiar place like working place or home. So in the more details, maybe we need to ask about the type of the public transport patient use. Also, the university campus need to use YCAN or not. In working tasks, patient use the 10 times magnifiers for new tasks, and also soft copy lecture notes with print out the larger form exam paper, and university will give extra time for the exam, and using the laptop can increase the font size and the screen reader. In lifestyle, patient can do independent works and eat and also cooking. And additional, we need to ask also, how about the patient additional to sunlight? Do she use any using sunglasses? And also in sport, patient not mention any sport she do. Next. Okay, this show that the first time patient visit for using the answer test, right eye not any report like with the within the normal limits, not normal, but the left eye superior parts got severely in the temporal side. Next. So this one is test about the visual field. This diagram show that patient outcome is like the visual field is quite narrowing for the both eye. Okay, next.
Okay, so for the diagnosis and management is we diagnose is a congenital nystagmus secondary to the congenital cataract. So there is a sensory nystagmus resulting from the early visual aspiration. Okay, so it's no need for no point training as the patient already adopt the clearest part primary gaze for the fixation. So another diagnosis is uncorrected refractive anisometropia. For the right eye is myopic and the left eye is hyperopic. No spectacle correction prescribed as there is a minimal visual improvement and no benefit for nystagmus control. So contact discussed as an option, but the patient was not interested. So, and one more is the cross-rate visual field. So previously identified via the Gerard's screening test. So we management is the TCF for the Gomez perimetry to further the assessment the peripheral field of loss. And the TCA also for the slit lamp and the fundus examination to evaluate the ocular health. So for the stepiness on the left eye esotropia and the right hypertropia, so that is detected during the cover test. So the TCF for the prism cover test and Quinsky test and the stereosis assessment as a base data for the possible prism prescription the trial. So next slide. Yeah. And the patient is a low vision aid recommendation. For the near is a assemblage illuminated stand magnifier. So it's using the f times for the 24 diopter 0.8 meter at 0.8 m at 11 cm. For the distance is the Spectral monocular telescope. So it's a S-type, 20 mm, equivalent to the 6 per 12 minus 2. So the management is a TCA with current magnifier to review the near vision and reading speed. So can we try of new magnifier if current one from suboptimal? So can we training and on the tracking and the spotting using the both aid in purchase? Patient education and rehabilitation advice is educate about expected limitation of the low vision aid, especially reduce the field of view and the advice to use extra illumination for the near task. The encourage to the travel with companions in unfamiliar environment and suggest joining NGO or support group to reduce the social isolation. Yes. Discussion.
Next is a discussion on the infantile cataract and associated eye disease in infants. So the overview of infantile eye diseases. Infant can be affected by various eye diseases that may lead to visual impairment or blindness if not detected and managed early. Among those conditions, congenital cataracts represent one of the most common treatable causes of visual impairment in infancy. Other significant eye diseases that can affect infants include retinopathy of prematurity, congenital glaucoma, retinal dystrophies, and optic nerve abnormalities. Next is congenital cataracts in infants. So congenital cataracts, like those like those experienced by our patient Misha, who underwent cataract surgery at age 4 on the right and at the age 6 for the left, occur when the lens of the eye become opaque during fertile development or early childhood. These cataracts can range from small dots of opacity to complete lens of opacification. The condition occurs in approximately 1 to 6 per 10,000 live births, making it a relatively rare but significant cause of visual impairment in children. Next. The next discussion is the development of congenital cataracts can be attributed to several factors. Okay, firstly is the genetic factors. So approximately 50% of the congenital cataracts have a basis, often following autosomal dominant inheritance pattern. Secondly, intrauterine infections such as rubella, zytoplasmosis, cytomegalovirus, and herpes simplex can cause congenital cataracts. And thirdly is metabolic disorders, so such as galactosemia, which is a rare genetic disorder where the body cannot break down galactose, and diabetes mellitus in the mother. And next is the chromosomal abnormalities such as Down syndrome. And lastly, idiopathic causes where no specific cause can be identified. Next.
Okay,
And
so next will be consequences of the infantile cataract. So sensory nystagmus will be as seen as in our patient. This develops when normal vision input is disrupted during early vision developments. So for amblyopia as well, reduced visual acuity can be that cannot be corrected by optical. So means alone due to abnormal visual development. For the strabismus, misaligned of the eyes, which our patient demonstrate with her left eye isotropia and right hypertropia. And delay visual maturation, slower development of visual acuity and other visual functions. So the photo side will be like showing that what the patient was having. So next. Okay, so associate condition with the different diagnosis as well. So persistent fetal vasculature (PFV). So it's formally called the persistent hyperplastic hypertrophic vitreous. This condition often present with unilateral cataract and micro So, and another one is aniridia. So, absence of the iris often associated with the cataract and glaucoma as well. So, retinoblastoma, so while it's rare, but this malignant tumor can sometimes present with leukocoria, similar to the cataract as well. So, retinal dystrophies such as labral congenital amaurosis, which may cause assist with cataract. Metabolic disorder, so galactosemia, low syndromes, and others. Next. So the next discussion will be our management consideration. The management of the congenital cataract require a multidisciplinary approach and timely interventions. So at first, we have the surgical timing. Current evidence suggests for the bilateral congenital cataract, surgery should be ideally be performed before 10 weeks of age to optimize the vision outcome. Like these patients actually will be cataract surgery on the age of 6 and the age of 8. So it's some kind like slower treatments. Optical corrections. After cataract removal, infants require immediate optical rehabilitations with contact lenses, intraocular lenses, or glasses. So that's why the empire cannot be upper. So that's why the next management will be amblyopia therapy. Patching of the better seeing eye may be necessary to promote visual development in the affected eye after cataract removal. So low vision services like early referral for visual rehabilitations as our patient eventually require with her magnifiers and other sets. So we actually, for the next slide, is our references. So we actually have one result sharing. Due to actually these cases, we found that the information is not like that enough. So, and we accidentally delete one of the pages for the result. So let our cosmet share the slide first. Wait for a while, yeah. So this patient actually got visit two times within 1 week, 1 to 2 weeks times. Due to the screening plan will be different. So the first time they are getting the VA, his bird retinoscopy and subjective refractions. Um, can someone share the slide? Wait, sorry for that. Just give us a second.
Yeah, this is the first one.
Okay, so this is the first visit. The VA for unaided actually is 1.04 logma at 4 meters. The VA after converts will be 4 over 40 minus 2. So for the left eye will be 1.06 logma at 3 meters. So after converting to the 6 it will be 3 over 40 minus 3. So the both eye can be seen like 1.04 logma at 4 meters. So but the head tilt to the left and squeezing the left eye. VF for near unaided will be 2.5 m at 20 cm. Left eye will be 6 m at 15 cm. Both eye can see 1.5 m at 11 cm. Reading with speed at 67.74 words per minute. So Hirschberg will be seeing that the left eye is isotropia, right eye is hypertropia. Retinoscopy cannot perform on right eye, but the left eye can get like minus 050, minus 050 at 690. Saturated refraction for distal will be minus 125, and for the left eye will be plus 150, which can only be see 1 meter at 40. So the pinhole is not improvement as well. And then the both side addition will be plus 1, which can see until 2 m at 11 cm. The bottom one will be showing the EOM. So we can see that like the null point will be at the lower I mean the lower part at the center lah. And the next one will be the second visit. Second visit, actually, the patient was screening for pupil, slit lamp, EOM, fundoscopy, ophthalmoscopy, and then IK, null point. So this is the result. So the pupil will be showing RAPD, but not mentioned is it whether it's positive RAPD or negative RAPD. So the SLE will be seeing the pupil location and also the pterygium. So the clearest points were at the center if E or M, and then fundoscopy could not be taken due to poor presentations. So ophthalmoscopy can see the fundus at clear and orange background. Macula cannot be seen. Optic also could not be seen. So IK tonometry could not be taken. Null point already using the clearest point at the primary guess. So, and near VA will be 2.5 m at 17 cm and 8 m at 20 cm, 2 m at 16 cm, 139.86 words per minute. So near magnifier can be used the illumination stand magnifier with at times 24 diopters. So which can be only for right eye and can see 0.8 m and 11 cm. This one VA still like 1.04 at 2 m. So this is, I think, is wrongly recording. So distance added will be well monocular telescope at time with 20 mm with 6/12 minus 2. So due to this, V6 just only stated at 2016 and no more after follow-up. So which means I think that's the best management on that particular time. But if convert to currently, we have the cerebral management for to better suit these patients lah. So that's all for our sharing today.
Thank you, Group A. Okay, just want to understand why the assessment result is presented separately. You said something, but I missed out that point.
Oh yeah, we actually accidentally delete that slide.
Oh, deleted. Oh, accidentally. Okay, okay, got it. Okay.
I bet.
You did that. Okay. Okay, thank you for the presentation, Group A. Yeah. Okay, well presented. Okay, but a lot of things that can be discussed through this case. Yeah.
Yep.
Okay, can we go to the slide one by one first? Okay, go to the first third slide. Yes, this slide. Can you put it in the slideshow? Yes, thank you. Okay, if you see the first point, chief complaint, right? The patient is, okay, basically this patient is having congenital cataract. Secondary to that patient is having nystagmus. Okay, so that's the basic case, yeah? Okay, now, patient is having congenital cataract. Okay, but why patient is having difficulty in dark adaptation? How do you relate this? Congenital cataract, nystagmus, and difficulties in dark adaptation. Is there any relationship that you can actually, find? Anybody can answer this. Okay, now we're going to start with the discussion. So it's not only for the group, but anybody can answer. Anybody can come with a point to discuss now.
Yeah, that's why our comment also there like difficulty
Yeah.
in that question mark.
Anyone else in the meeting who actually have opinion on this? Why the patient is having this?
Okay, I said that because due to the lead treatment, then the eye development will be delayed. So that's why the photoreceptor there is not like really well development, and also like really well the vision will be starting to getting like impact repair after this. So
Because
that's
of
why
what? Because of what was what was the cause that
the eye development issue,
Late develop.
late treatments,
Uh-huh.
and also due track to the eye development will be getting slower. So that's why there might be like the macular day, the photoreceptor will be getting lesser or not developing well.
Mm. Okay, that makes sense.
Mhm.
Okay, because when patient is having cataract, that light that goes into the eye is actually kind of
Lesser.
blocked.
Mhm.
Okay, so since the light is not reaching the the behind layers, the retina, so that never induce the development of the rods fully. That could be the reason why. Okay, so okay, good. Okay, that is number one. Okay, why do patients see wavy lines?
Mm. Might be due to the nystagmus.
Nystagmus, okay. The world is shaking, so see. Because the cataract is already removed,
Yep.
Okay, if let's
Yes.
say the patient's cataract is not removed, then high possibilities for them to see the wavy lines. Okay, because of the obstruction of the light and all that. But the patient's cataract is already removed. What could be the reason?
But the VA is not good.
Maybe
That's why baby
maybe
line.
because of due to the post cataract removal complication.
Uh,
Or
not
there's
really.
underlying retina issue before the cataract removal.
Did you check the? I mean, did we check the fundus? I mean, based on the finding.
Yeah, fundus
Yes.
has been checking, but cannot getting the macular part, and also just only can see the background
Because
color.
she's having nystagmus.
Mm-hmm.
Mm-hmm.
Can move to the second page of your complaint, the retina's result.
Retina result.
Yeah,
Wait,
I thought I see something like she have a retina pigmentosa.
That is the
Oh,
husband.
that one,
husband.
Husband.
That one's husband.
Vicky, yeah.
Wait, retina
Six and
the one
seven.
pigmentosa is husband.
His husband, yeah, correct. There was no family
yeah.
issue with retinal blastoma on these girls lah.
Mm-hmm. Okay.
Summary HP husband had to be out, right? Cannot be there.
No, just because is mentioned inside, so we just want to put in.
Oh,
We just
And
just
yeah.
added.
okay.
Okay, so
And
this go back to the slide, can we
Can. Yes.
Mm.
Okay. I
Okay,
like.
so this wavy line complaint, right? It is quite common among patients who have. Is she inserted with IOL lenses? Is that mentioned in the somewhere? Did I miss, or is it mentioned or not mentioned?
not mentioned.
Not mentioned. So we don't know whether there is IOL lenses or not inside. Okay, so okay. If let's say IOL lenses, then it's quite common to see wavy lenses. There is a term, if I'm not mistaken, like dystopsia or something, dysphotopsias or something like that. I have read somewhere. Okay, where the patients who are actually with IOL lenses will have this, symptoms where they will see wavy lines because of the surface of the IOL lenses or the edges of the IOL lenses that causing them to see wavy lens. If let's say IOL lenses are inserted in lah. What is the refractive error? Yeah. No need to change the slide. Just let me know if you still remember what is the.
Yeah,
I couldn't recall.
Minus 1.25.
Okay, not so
Right.
high.
Mhm.
So, do you think IOL lenses there in the
Yes.
eye?
yes.
Yes.
For me, yes,
Okay.
because due to if no IOL, the power will be significantly different.
My ear.
Mm-hmm. So because the
Mhm.
power is actually very low, so you think the IOL lenses are inserted in, okay? So we can assume that, okay, because so in the future when she comes back, then we can ask Lisa whether she was inserted with IOL lenses or not. Through the slit lamp results, it's not mentioned also, is it?
Just
Yep.
mention the bit.
Yes, mention
Okay. And
with the highlight.
anywhere in the history that mention on that?
Mention on?
IOL lenses.
No.
No.
Did you? I
No.
don't know which case lah. No PCOs reported. Is
Yeah.
it in? Okay, can you go to that slide? So that if let's say they're talking about PCO, that means IOL lens is inside lah. It's another a way of confirming that because they have discussed about it.
No,
Okay.
because the not mentioned PCO is from our side.
Oh, okay. Not
Yes.
them. Okay. Okay.
Which means we only get the info that patient did the cataract surgery during 4 and 6 years old, but we
But
don't
usually
know
at that
any
age, right? They don't insert in IOL lenses. That's why I'm doubting. Okay. So this one we have to put it on pending lah. But just for your information, patients who are inserted with IOL lenses, usually not all, but they are complaints like wavy lines, quite common. So if let's say you have patients in the future, okay, that who has done cataract removal surgery, and then when you do Amsler chart, right, and they do see wavy lines, but when you check their fundus or do OCT, nothing is there. Okay, so don't be surprised. Okay, so don't be surprised. This is quite common. Okay, so when you give explanation to the patient, you can explain them, okay, that it could be because of the light that passed through the lenses, or it could be ages of the IOL lenses or the surface of the IOL lenses that leads them to see the wavy lines. Okay, so this kind of explanation can be given to the patient. Okay, rather than say that, oh, everything is okay, but I don't know why you see wavy lines. Okay, and you can Google for the, I think it's this dystopsia or dysphotopsia lah. You can Google for it. Okay, so that is one new information lah. That I thought I should share if let's say you don't know about it. Okay. Okay, next is why do patients see flashes and glare? Okay, what we are trying to do now is we are trying to understand, how the symptoms is related to the problem that the patient is having. Okay, so could you explain, anyone, okay, not from the group members, why do you think the patient report flashes and feel glare when using computer? She is having nystagmus, cataract is already removed. She is having a low VA. How that this flashes is all related? Anybody?
Sorry, what's your question again? Can ask again.
The question is, why do this patient report flashes and feel glare when using computer? How that is related to the condition that the patient is having? That's my question.
Is it because the cataract and also because of the high astigmatism of the nystagmus patient? Normally, nystagmus patient astigmatism is high.
But this patient doesn't have astigmatism, and patient already removed cataract. So both are not explaining that.
Can I
Yeah.
mention?
Yes.
Okay, Alex
Who
first.
wants to start first? Yes.
So okay, so
I think it's a ocular surface.
Ocular surface of
A
what?
dry
Yeah.
eye.
dryness. Okay, dryness could be possible. Okay, other than that, something that okay, I'm not saying that it has to be related to the condition that the patient is having, but we are just looking if, let's say, there is a connection or not, so that if you see this kind of patient in future, you know that when patient complains this, you know that this is because of this particular reason. So that's what we are discussing.
Yeah.
Yeah.
So actually, for my point of view, will be so due to the patient is really young to getting the cataract surgery, so
Mm.
that the photoreceptor part or the optic nerve part actually is very sensitive. So there's once when using the like the gadget or the screening, then there will be feeling glare because it's very sensitivity to the light. For the flashes will be might be the over sensitivity and all like overreact to the light source as well at the retina part. Is that
Mhm.
related to this?
Okay, that makes sense lah, because it's
Mm-hmm,
the retina is not fully developed.
mm-hmm,
So the retina layers are not fully developed. So we don't know whether the RPE layers are fully developed or not.
mm-hmm,
So the pigmentation, the macula pigment areas. Okay, so when the pigment, when retina is not fully developed, okay, and we expect the layers in the retina also to not fully develop lah. Okay, so when it is not developed, the function is also not to optimum level. So we expect the layers which has pigments to absorb excessive light when they're
mm-hmm.
exposed to excessive lights, right? So now that development is not full, the function is not full, so absorption is also not full, not to the optimum level. So that could lead them to have this also. Make sense?
Yep.
Okay,
For my
so it tries what we are trying to do now is trying to relate to what patient has, so that we know that if, let's say, this kind of patient comes, so this could be the reason why. Okay, according to the motility test, okay, it is mentioned that patient doesn't meet a null point, right? Okay, but I saw somewhere in your history or what that patient have a head tilt. Where is it? Huh? Somewhere.
for the first visit, the VA
Where?
part.
Oh yeah, need to tilt head to look aside to see better. So when patient is actually tilting their head to to look at somewhere, that means they have the null point already there. Okay, that means when they tilt their head to the right, for example, okay, right, that means the null point is here. Okay, so that's why they are actually tilting their head. But why, when you do a ocular motility test, the examiner did not detect that? Why do you think? Supposedly, if, let's say, I turn my head like this, to see clearer. So when I tilt my head, my nystagmus gets lower, I see clearer, right? So that's why the patient is having a head tilt. But now, according to the motility test result, it shows that the patient having the primary gaze as with the least magnitude of nystagmus. It's contradicting. Why? I don't want the group member to answer.
Maybe
Someone
because
else.
of the EOM, they test the patient head didn't move.
Memang cannot move one motility test.
Yeah, the patient actually had to tilt his her head, right, to see clearly, right?
Mm-hmm.
Okay, but motility test, maybe the patient head didn't move, just move the eye.
Okay, Benjamin. So you already see my recording for nystagmus lecture, not? No, haven't, is it?
No, haven't.
I have. Okay. So it's not the time. Okay, I'll explain. Yeah. So basically, when a patient is having nystagmus, right, we do a motility test. Okay, so the motility test is to see at which gaze patient is having lesser movement, okay, of the eye when they go to extreme gazes, primary gaze and all the extreme gazes. If let's say they actually have the least gaze at the right side, right? Okay, if let's say when they turn their eyes to the right side, okay, if let's say I'm the patient, right? If I turn my eyes to this side, I'm actually having the least magnitude of nystagmus. So what I have to do is I have to turn my head to the opposite side for me to see clearer. Okay, so now the patient is already tilted, okay, the head seeing clear. But when I ask the patient to look straight and do motility test, the result is not showing that at this gaze patient is having least movement. Why? That's my question. Benjamin, do you get what I say?
Mm,
No.
let me make
Now
it
it's
clear.
reverse. You already know the answer. Patient tilt head to one side can see clear. But then when I go straight, he has to see, at this gaze to be with the least magnitude of nystagmus. Now he's not seeing that, or the optometrist is not observing that. Why? Any possibilities also can be there. Why very quiet today? All penat Penat do geriatric clinics, is it?
Or they're wrongly tested or wrongly recorded.
Hey, who's talking? Yeah, talk louder a bit. I don't know who's talking. Talking, yeah.
Hello,
Yes.
can you hear? Yeah. Is it the examiner, I mean the clinicians misrecorded or what?
Yeah, possible. Okay, possible. Alex, is it the one who was talking?
Yes.
Okay,
Okay.
Alex. Okay, possible because if let's say the patient never reported that when they turn their head, that they could see better, then I wouldn't have bothered about the motility test. Okay, but now the during the history taking patient mentioned this. So when your patient mentioned that when I tilt my head to the side, I could see better, then you have to ask which side. So that is another point that is missing here. Okay, so in future you also have to do the same thing. If let's say a patient with nystagmus comes to your clinic, okay, and they say that okay, when I tilt my head to the one side, I could see better, then you have to ask them which side is that, that you're turning your head to. Okay, or observe them while they're talking to you, maybe they're turning their head to the left. Okay, so when you do motility test, you have to pay extra attention, okay, on the right gaze, which is opposite to the head tilt. Okay, so if let's say the patient has a tilt at up, right, okay, tilting up the head to see better. Okay, so when you do motility test, you have to look at the inferior gazes, okay, the down gazes, okay, to see whether the magnitude is slightly lesser or not, because patient could see clearer with the head tilt up. Okay, so this is the basic. Since you haven't have lecture, right, for nystagmus, you can watch my video already uploaded. Okay, but this is how you deal with nystagmus patient. Okay, we already cover one patient in the beginning, right? So now just a continuation of that. So this tilting head and null point are all related to each other. So number one, when patient comes in and say that I have a head tilt, I can see better with that head turn or head tilt, ask them to which side or observe on which side. Record down, and then when you do motility test, you observe or pay extra attention to the opposite direction of the head tail. If let's say it's towards the left is the head tail, then you should actually pay extra attention to the gaze of the patient when they turn their eyes to the right side. Okay, to the opposite side, and see whether there is any change, even by a few percentage of lowering in the magnitude of nystagmus. That could be the null point. So this is how you make sure that you don't miss out things. And also, if let's say patient already have this kind of complaint, right? you can test yourself, whether you're doing the motility test rightly or are you observing the nystagmus magnitus efficiently or not. Okay, so that is one. Okay, next question is, I already explained this, in the previous nystagmus case. How cataract and nystagmus, how do patient get nystagmus? After having congenital cataract, how does this congenital cataract causes patient to have nystagmus? I've explained this. Anyone not from the group to explain? Why very quiet today? Hello? Anybody in? Am I talking to myself?
No.
No, you're not. You're not.
You don't know the answer, so you quiet.
No.
The silent is a bit, very long than what usually this first batch of BSc will do. They can talk non-stop, they can ask question non-stop, but today it's like, something is not right. Okay? So
But
my question again, congenital cataract, how does that induce nystagmus on this patient? I already, we already discussed this in the previous nystagmus case. Okay, anybody can recall?
is a injury of the muscle that control the eyes during the cataract accidentally injured the eye cause.
No, no,
There's
that's not the result.
maybe a tumor
No,
inside the brain compressing.
no. I explained this already in the previous nystagmus. Anybody can recall?
Is it because congenital cataract forming it block the input during the critical period visual development,
Visual
something like that,
development at the
then
they
cause a
were
nystagmus.
at the fovea. Yeah.
Yes. Thank you, Benjamin and Vicky. At least someone remember this. Okay. So how does patient get nystagmus is, okay, because patient born with cataract, so the amount of light that is reaching the retina until she got her cataract removed at 4 to 6 years old is actually very limited. Okay, when it is limited, okay, the growth of the fovea is affected much for this patient because from infant up to 4 to 6 years old, it is, the crucial age, the critical age for the development of fovea. Okay, so since there is a cataract blocking the light that goes in, so the fovea doesn't, receive enough input for the development of the fovea. So that is what happens because of cataract. But how does that lead to nystagmus? That's the next question. Okay. So how does that lead to nystagmus is because fovea, if let's say fovea is developed, right, it works like a magnet. So whenever that light goes in, okay, it goes directly to the most sensitive area, which is the fovea, okay, for the information to be processed. Okay, but now because of the obstruction due to cataract, so there is no sensitive area that has developed because of, there's no sensitive, the most sensitive place is not developed. So the eye will be keep wondering if, let's say, I turn my eyes this side, maybe this could be the sensitive area. So it tries that position. Then when it is not sensitive also, then it will try another location. So that makes the patient's eye to keep moving, okay, because, continuously looking for the most sensitive place in the retina, okay, which is supposed to be fovea because it is not developed, so it keep moving. So that is one of the reason why the patient is having nystagmus. Okay.
Okay.
Okay. Okay, what is the aim of the patient? Why patient came to the clinic? It's written
Because
somewhere.
yes, here. Patient want to get a clearer
Okay.
distant vision and near vision. because she's
Wanted
a student in a university.
Okay, so wanted to have a clear distance vision because she wants to look at the lecture slide, and also the near vision because she needs to read books and lecture notes. Okay, but she's not happy with the current one lah. Okay,
No, she don't have current spectacle because she stopped using her spectacle during 16 years old because of dizzy and discomfort.
okay.
Mm.
Okay, now if let's say we look at this question, right? Okay, this is the information is not enough. Okay, what are the additional information that you have to ask? Okay, record down somewhere. Okay, these are the questions, whatever that we discuss now, these are the questions that I'll ask you during your practical exam. Okay, that's why we are having all this low vision case discussion. Okay, so I will ask during your, practical exam. So basically, okay, if let's say a patient comes in with a complaint that cannot see lecture slide, there are some additional information that you have to ask. Whether they study in a classroom like you all, or they study in auditorium. Okay,
Yeah.
that means lectures are in the classroom or lectures are instead, in auditorium. It's two different, measurement when you want to, prescribe them with many devices. Okay, because classroom will be shorter distance. Okay, auditorium will be longer distance. So the vision is not, the requirement is not same for classroom and also the auditorium. And also question number 2 is where the patient is actually sitting in the auditorium or the classroom. Is it the front row, back row, or middle row? So that is another additional questions that you have to ask. Okay, so in future. Okay, then okay, so she wanted to have this too. Okay, by the time she got discharged, did we give solution for this two problem?
No,
No.
the management.
So according to the management, no glasses could be prescribed because there's no improvement. Telescope is not practical, so that is not prescribed also. Or did you? No. No, right?
No prescribed.
Okay, no. Glasses also cannot be prescribed. Okay,
Yeah.
and then telescope also not, not possible, so not recommended. Okay, but then you mentioned that you asked patient to request for lecture notes earlier. Am I right? In
No,
soft copy.
it's a patient history.
Habits.
Okay,
That
so
means
she,
the university will send the soft copy to her,
okay,
and
so
during the exam, so
mm.
university will prepare a larger print.
Okay, so that is
Yeah.
already done over there, lah.
Yes.
Okay, so basically, the distance vision that she needs is for her to move around, to go to unfamiliar places and all that, right? To use together with the white cane.
Yes.
Yes. Okay,
Yes.
but we couldn't manage this. Okay, we couldn't manage this. Okay, in the management, did they mention anything about this? No.
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 So they tried a telescope. Okay, but KIV training and tracking and spotting both aids if purchased. Okay, so basically the patient is no interest in purchasing telescope lah. That's why we never train. Mm-hmm.
Some more the patient currently is pregnant, so the mortality, everything is like getting lesser and lesser lah.
Mm-hmm.
And one
Okay, if
question
let's
from
say, wait, I just complete this thing, Okay, if let's say patient comes with, expectation, we do assessment, we try the management, but we cannot actually do anything about it. Okay, so the next thing that you have to do is you consult the patient. Okay, tell them that you have this problem. We tried this, we do assessment, we tried a few these devices, but it's not working for you. Okay, so educating the patient in terms of the problem that they're having, and also the limitation or that we have with our low vision aids or the management has to be clearly explained. Okay, I like the point that you have written, the educated about the limitation of the low vision aids, right? Okay, but I think that one is more to the field of view. But the 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 important one is you answer the the or you
Complaint.
yes. Okay, so patient come and complain, we cannot do anything. It doesn't mean that we just say that, okay, I tried this, cannot do this. Okay, we tried this, but it's not helping you. That's it. You have to explain why is it, like this. Because, the fovea is not developed. So if let's say even we prescribe also, it's not going to, help you much because, the fovea is not fully developed for you. So explain that so that patient, when they leave the clinic, they know that this is what happening to the eye. Okay, so explanation is very important in low vision clinic. Yeah. Okay. Okay. There is one interesting part. Can you go to the third slide again? No.
This one.
Where is she working? Somewhere. It's mentioned where she working. Where is she working?
Yeah.
Somewhere there.
That's dialogue in the dark.
Okay. Do you know what is dialogue in the dark? Anybody?
Jennifer, you search, right?
What is dialogue in the dark?
The Blinder Association.
Mm-hmm. Okay, this is important for an optometrist to know. That's why I'm asking you this question. Anyone has the idea? It's okay, Jennifer, if you don't know. But anyone else heard about dialogue in the dark? Anybody heard or went for dining in the dark in KL, Bukit Bintang? Anybody?
Yeah.
Who went?
Yes.
Who's the yes?
Yes.
I didn't go, but
But you know.
I know
I
there's
went.
a
I went.
place.
I went a couple of times.
Okay, who went? Ray went, is it?
Yeah.
Okay, Ray went, but the others no. Okay, those who have no idea at all. Are there anyone who has no idea at all? What is this? It's okay, no need to be shy. Even in the beginning, I also don't know what is this. What is dialogue in the dark? What is dining in the dark? No, it's okay. I'll explain. Okay. Yes. Somebody want to
It's
explain.
a association enterprise that immersive experience where visitors explore familiar environment in complete darkness, guided by visual impaired individual.
Correct. Okay. So basically, this dialogue in the dark, right? Okay. It is like a simulated place. It will be like one room, not one room, like one large hall kind of thing. Okay, where you will be blindfolded. Okay, and you will be using white cane, and you will be guided by blind or low vision patients to move in a room which is complete dark, pitch black dark. You won't, even if you open your eyes also, you cannot see anything. And that place will be simulated like there will be like cafeteria environment that is actually enacted by the visually impaired person also inside. Okay, so they do have like a park, they do have like a river kind of simulated one, and you have to cross the bridge. So it gives you an experience of how life of a visually impaired person. Okay, so that is dialogue in the dark, but now they have closed it. Okay, because they shifted from one place to another place, and I think they're going to start soon lah. If otherwise, I would have actually brought you all there. Okay, usually we bring our students to MAB and also dialogue in the dark before they graduate. Okay, so that they have experience, the service that is provided, okay, in MAB, and also experiencing themselves, in a pitch dark places, and so that you appreciate your vision kind of thing lah. And dining in the dark also same concept. You will be eating in the dark room. Okay, so the restaurant will be like, the restaurant is in Bukit Bintang or Bukit Nanas. I'm not sure. Bukit Bintang, I guess. Okay, where the restaurant is like pitch dark, and then the food will be served with you blindfolded. Okay, so you eat by only tasting the food over there. Okay, by touching and tasting. Okay, so you won't know where are you in the restaurant also. You'll be guided by the visually impaired person to your table, and then food will be served, and you have to eat without opening your blindfold. Correct, Ray? Because I have never been there.
Yeah, sort of that. So the
Mm.
whole process is actually they will guide you to the seat. So they will explaining you what are the tools in front of you. You go and touch yourself because it's completely dark. It's not blindfolded.
Yeah.
It's a room that is completely sealed.
Correct.
So you can't see a light except the CCTV, the kind of infrared lights. So you're gonna expose yourself or what are the in front of your table.
Even the food also you order earlier, right? What the
they
course
ask
meal that you
you,
want.
they ask you whether you have any allergies of the food. So there are a couple of sets for you to choose. In fact, you are not the lamb person or the whatever lah. So you need to preset first. They don't tell you what they are going to cook, but the ideally is they want you to experience the food and bring more sensation to the others besides our eyes, because we used to see a lot before we make a lot of judgments, right? So this is while you eat, you're going to taste by your tongue, and then what is this? And then you're going to experience yourself what is an ingredient they made. So end of the sessions, they're going to have about 3 to 4 course like that. So all are boneless, of course. So they will bring you to a slightly brighter room, but it's not completely bright because you're going to have a little bit of grace period when you're moving from dark to the bright. And they will give you some idea what they actually cook, what you actually eat just now. So that's the whole experience. It takes about 2 hours like that. It's quite a good place, but it's more to a conversation place. Or you doesn't allowed to bring your phone. There's a locker. Before you enter in, you're gonna surrender all your smartwatch, your phones, and then you completely just sit with your partners and just chit chat and discussing about the food. What is this all about? Yeah, it's quite interesting.
Maybe y'all can plan because you will be coming for your exam, right? Maybe the last day of exam can go for this kind of dinner. I mean, if let's say you have time, at least you experience it once lah, because it's very interesting. We wanted,
yes.
because I wanted to bring the students one of the batch, but we couldn't make it. So we went to dialogue in the dark, and maybe only. So maybe we can try one, okay, before you graduate. So you can do a discussion of what kind of food that you eat lah. Okay. Okay, so that is one thing that you have to know. Okay, this dialogue in the dark is actually, organized by Malaysian Glaucoma Society. Okay, so Mr. Stevens Chan is the president and he's the one who conducts it. Okay, if you wonder who is Mr. Stevens, right? If you still remember the Yao's Bash, they made video of interviews of patient, Dr. Fu and myself, right? So you go and check that Mr. Stevens one. So I think he mentioned that in the interview, if I'm not mistaken, regarding this. So that is he's the one who does it lah. So he shifted to many places. Last time they have it in Kevin, you should know what. Last time they have it in the well, okay, where you had your practice also. So the well,
Stevenson, yeah.
yes, yes,
long time ago. He's still doing.
yeah, long time ago. Yes, like
Long
2014, 15. That
Yes.
time we brought our patients. I mean our students over there.
Even
And
Mapo
then
time also, we donate money to him also.
yes.
Stevenson.
Yes, Stevenson. So then they shifted to somewhere in Sunway University. At that time also I was still bringing my students. We also supporting lah because when we pay they get money, right? So usually I'll bring the students and it's one person's about 30-35 ringgit last time. I don't know how much now lah, 50 ringgit or maybe. Okay, so used to contribute there also. So now I think they're planning to get one place like he told me, but I couldn't recall. So maybe once he opened, then you all can go one day lah. Okay, so this one you have to know, yeah? Just a simulation center for you to experience, how a blind person walk around and how do a blind person that is in dialogue in the dark and how do a blind person eat in the dialogue in the dining in the dark place. So you all can, maybe plan for it lah one day. Okay. So So that is one thing additional. Thank you for mentioning that she's actually a facilitator in Dialogue in the Dark. At least we can discuss this. You as an optometrist, you should know this. Okay. Thank you for bringing this topic. Okay. Okay. Next thing is, can you go to the Jerem screen result somewhere? Jerem.
Yeah.
Okay. What is not right about this Jerem screen recording? I get very angry when I see this kind of forms.
What style of simulator they use?
Correct. Then what else?
Right and left.
Any
The right and left is
Whether
no. Right and left is
with
already.
power or without power, whether with correction or without correction.
Okay. What else? Okay, if you see the drawing, right? Based on drawing, okay, can
know
I
where is the
actually
scotoma.
assume this to be a central scotoma or not? Rather than tunnel
Can.
vision. Can, right? Why?
Yeah.
Because there's
they
no
never
shading.
shading.
Yes, shading is important. If you don't shade, right, I can. Although you as an optometrist, you know, right? Okay, so this is, what patient could see. But if let's say there is no shading, right, we don't know. If you see the blind spot and the central one, there is a gap, I can assume that, the blind spot should be, whether patient can see or patient cannot see. So it's very confusing. So the shading is very important when it comes to this, recording. Okay. So this is one thing, I mean, you won't be doing this, but when you do it properly. Okay. Okay. Next is, okay. You all, according to this report, right? Jerem screen is already conducted. Amsler is conducted, but why there is a Goldman parametry somewhere? It's written somewhere. Where is it? Huh?
Constricted visual field. Bowman perimetry.
This one you suggesting
TCA.
or they suggested?
They.
They suggested.
TCA.
Why do you think they want to do a Goldman when Jerem is already there? Any idea why? No, this is just a discussion. Not saying right or wrong. Just wonder why. Do you think do you think patient has to do it, or you need to do the assessment if let's say you see the patient in the next visit?
Not that necessary for me, because
What's the
she
nine
mainly wanted to look straight during the task. She did not mention she wanted to try and have a wider visual field. So ever since that the Jerome has shows that the center it's clear. So yeah, it's not really necessary unless there's other suspicious. They want to test whether what are the visual field has affected through the developments and understanding the eyes of conditions.
Okay, so that is one perspective. So according to Ray, he said that we all based on the need of the patient, Jerem screen result is enough. Okay, so no need to do a further assessment. Okay, is there any other perspective that anybody else has?
I think they mentioned it because it's due to suspicious or worry about the glaucoma thingy, because since like the pupil showing in the slit lamp also not like very normal, so they might be worried about the vision, the IOP pressure, because due to the IOP also cannot be performed at that time, cannot be detected.
Okay,
So
because of the nystagmus.
yeah, because of the nystagmus as well. So that's why the government perimetry, they are needed to take it like to rule out the glaucoma issue for my perception now.
Okay, that is another perspective. Yeah. Okay, we think we no need to do that because we already have a Jerem screen test. Okay, we already have result. Memang already show constriction. Okay, but another perspective is if let's say they do Goldman perimetry, they can actually get a better result. Okay, because the suspect of glaucoma over there because cannot do GAT or eye care on this patient. Okay. Any other perspective? In my opinion, right? Better don't kacau patient again, because doing Jerem and Goldman perimetry, it takes about similar time only. Okay, just that a different instrument. It's going to be tiring for the patient. And with this patient who is actually having constriction, okay, once you already done, okay, maybe you can monitor back after 1 year or 2 years. Okay, no need to monitor every time patient comes to the clinic, because we already have the idea of what patient is having. So don't kacau the patient too much. So I wouldn't recommend for Goldman perimetry lah. Okay. 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 Can you go to the VA recording or not?
Sorry.
VA
VA.
recording.
Over here. Can you see?
Yeah.
Okay.
I say the VA is done wrongly on this patient. How many agrees and tell me the reason why? The unaided VA for distance, I say they're wrongly done.
Because no
Yes,
need to
agreed.
write the meter.
Not about the recording. Even it was done wrongly. Why? Simple
The
only.
left eye, the 3 meter things one.
Supposedly,
Supposedly in 4 meters, and because of re-attacking, it's not like just screening the VA.
okay,
So
anybody else? There is one specific answer for this. Very easy. Anyone want to try? Whose alarm is ringing at 10:18? Very simple answer. You look at the right eye VA, you look at the left eye VA.
Yeah, it's very similar result, but one is tested at 4 meters and another one tested at 3 meters.
Okay. Okay, I will lead you to the answer that I want. Okay. What is the chart that is used to measure the VA of the right eye and left eye? One person answer. 4-meter chart or 3-meter chart?
4 meter.
Sorry?
4-meter chart.
4-meter chart. Okay, if let's say, okay, right eye, when patient is given, I know you put the chart at 4 meter, patient see the first line with 2 mistakes. Okay, that's why is 1.04 logma, correct?
Yes.
Okay. Left side at 4 meter, patient cannot see,
Yeah.
right? So you should move to shorter distance.
Yeah.
If you move to shorter distance, you should move to which?
2 meter.
2 meter.
Yes.
2 meter.
Now you see the mistake here?
Yeah.
Okay. Number 2, conversion also wrong.
Yeah.
Where got 440? It's supposed to be 665 something, right? When you convert the 1.04, you convert to 6 meter, okay? Snellen, it is supposed to be 6 something. Okay, what this student did was, okay, in that side of the Lokma chart, right? Okay, there is a value like this. So they just copied this without knowing how to convert it. So this is also wrong. Okay, so when you see, patients in future, right? Okay, because the first visit assessment or the previous visit assessment is much needed for us to do comparison, okay, with the current one. So if let's say the first one, if let's say we interpret or we understand wrongly, what will happen to the current one is when we do VA measurement again, if let's say, okay, If let's say we stick to this, we stick to this, we say that this is 440. Okay, and then we measure VA again this time. Okay, we get 660, for example. What we would think that, oh, from 440 to 660, so now got improvement, right or not? Wrong judgment already. So whenever you have like a previous report or someone refer the patient, make sure verify the results first, verify the findings first. Okay, it's not we're going to blame them that they are doing wrong, but at least when we explain to the patient, we don't make a mistake by interpreting the wrong thing because we never verify the first, the initial report that we got from some other people or from some other places. Or if let's say you're in our clinic, right? So from some other, the previous batch punya finding. This is very important, not only for low vision, for any result. Look at the finding, verify whether it's actually, correctly interpreted or not. Then when you get your findings, when you want to explain to the patient regarding the progression, okay, regarding the follow-up, right? Make sure you are interpreting the right thing. You got what I mean?
Yes.
Huh? Okay, this
Yes.
is very important. Yeah, verification of the findings of the reports that you receive is very important when you do a follow up and give them a feedback on what you have actually done on the visit that they come to you. It's very important. Yeah. Okay.
Mm.
So please do take this, seriously. Okay, that is number 12. Next comment, number 13. If you see the VA, right, it's actually worse after the subjective refraction.
Yeah. 1/40 for the left side.
Yes, okay, 1/40. And even the near VA also, it's 2M. It's about the same lah. Okay, not much. But then the distance VA for left eye shows that, it's getting worse lah. So this is also another thing that you have to keep in your mind before you do refraction, on that same patient, during the current visit. Okay. Okay, can you go to one picture? That slit lamp result.
This one.
Yes. Why do you think the pupil is not at the center as how it's supposed to be for this patient? Answer is very easy only.
Tropia.
Correct. Okay. Because of the tropia that the patient is having. Okay, thank you. So we no need to continue with that. Okay. And one question for your discussion today. Okay. This time discussion we take a shorter break. You can have your coffee break during the discussion. Okay. Related to this patient also, if let's say a patient is having tunnel vision, okay, if let's say a patient is having tunnel vision, when they use telescope and magnifier, right, is the field of view is affected more for this patient because they already have tunnel vision, okay, and they're going to use telescope and magnifier, okay, which is going to have a restricted field. Okay, so now my question is patient with tunnel vision going to have any issues in terms of the field of view when they use telescope and magnifier? Okay, telescope, magnifier, tunnel vision, and also field of view. How these three are related. Can I give you time until 11? You discuss, and
Okay.
then you at 11 we'll discuss this again. Can? Make sure
Okay.
everybody talk, huh? because my speaker will be on. Okay, just that I don't understand what you're talking because you'll speak in Chinese, but otherwise I know whether you're talking or not. Okay, can we start? Okay, you all discuss. We will resume back at 11 with the answer for this question. Okay, soalan cepu mas, huh? Okay, okay, I'll see you at 11. Bye bye.
Okay. See you later.
So 他讲什么？有一个 telescope，还有一个 item 这种 telescope。
他是说
Magnifier
怎么
magnifier 啊
magnifier 对
magnifier 没有太大的问题的。
因为他讲 basically 如果用 telescope 和 magnifier 的话 visual field 应该会小一点，就好像我们在 LV clinic 玩的时候不是更小嘛，这样子。但是如果 for patient with tunnel vision 再用的话，会更小还是会更
depends on 它的 tunnel vision 有多大咯，因为你看啊 ，it's like more to aperture 这样子的 idea 嘛。如果你那个 telescope 你放得越靠近，你的 aperture 自然就会大一点，因为你从attach to 你的 tunnel vision 嘛，反而它会看得稍微比较大。
对，这个 agree， 只是说他是说问什么有没有 relevant 跟 related， 我是说很像，其实要不要用这个 telescope 跟 magnifier， 其实是 depend on 他还有没有那个 ability to 看得清楚啊。因为如果你看如果是他已经 tunnel vision 了，然后你又给 telescope，so which mean 他 screen 的那一个 movement gesture 那些会更多。所以如果是说 telescope 如果能够让它的 VA 弄得变得更清楚的话，其实是可以啦。如果是 magnifier for near 的话，没有太大的问题，是因为你还是要 screen 嘛。所以就是他要看他的那一个 specific 的 VA 能够 achieve 到哪里啦。So let's say 如果是他只能够 achieve 到2M。连 magnifier 可能也只能够帮到他去到 4M 罢了，所以就算你的 field of view 有几大都好，都算是一个没有什么帮助到啦。
我觉得telescope 的话没有帮助到 because of 那个 field of view definitely 会 constricted 啦，because 它会更小嘛 for telescope。然后 magnifier 的话，它可以用 because 它是坐着的时候用，means 它是没有动的嘛。然后它的 text 可以 enlarge 啦，比较容易看到那种小字。这个是我的 point of view。
Agree。telescope 我们也是站着用的，不是吗？没有走着用的。
对，但是它的你看到的东西只是 maybe 0 to 5
更 limit 了啦。明白。
0 to 5 visual field，so 它已经 limited， 你再 limited 的话会更小，就好像我们看那个反的像用diopter。
明白。
它不是还有一个可以放大的咩？
有没有什么
那个是 reverse reverse 放大那个 field of view 啊。但是它的 VA 不好啊，你不是看萌萌吗？
可是没有 mention 它的 VA，
我们排除了它不是 VA 的问题先了，因为它的问题是说，如果这个 tunnel vision patient 他用这个 telescope 的 magnifier 有没有 any issue 嘛？ So 我之前 get 到的，因为我们在 low vision plus 的时候，他讲说有一些 low vision patient 他用那个telescope 的 benefit is actually 他可以看到更外面的东西，因为他那个 lens 的 curvature 它会让他看到的范围会更多。Of course， 就是你讲的站着啦，他是看了些我知道那边会有什么东西，然后他们才走。
那个是 reverse 的用哦。
所以它有两面的嘛，对不对？所以如果你问我，因为它那 vision 你在用这个东西，会不会让它更难看的话，我觉得
不至于，
我的认知里面是不成立的啦，是反而它会 benefit to 它。
他的 question 其实不是问在 tunnel vision 和这个 magnifier 的 telescope， 他的 question 是问在 the relationship between telescope 跟 magnifier 会怎样影响它的 depth perception 跟 the view。So 我们要答它的 questions the relationship between 哪一个？我们知道怎样是用，我们知道怎样去用 magnifier 大还是小。他现在是说要我们 find out the relationship 嘛 between 这两个。意思是说，你 tunnel vision 的人，你用什么 magnifier 去 improve 它的 depth perception，还是 improve 它的 field of vision？你拿到 depth，但是拿不到 field，拿到 field 还是拿不到 depth，something like that。So 如果是用magnifier with a lower magnification，它的 field of vision 会 improve 吗？This is what the question 啊。如果没听错啦。他知道他的 relationship 吗？为什么我们要这样做 ？So 比如说 relationship high magnification，你的 field of vision 的 drop
就是 lower drop。
So if you reduce 它的 field of vision，then 你的 tunnel vision 会看到这样更清楚还是更 blur？This is a question 啊。High magnification normally for tunnel vision is good for near world lah. And then low magnification for better field of vision. 不是啊，是不是这样的answer还要
agree。
所以他说是很 short 的 discussion 的。
如果 VA 好的话，用 telescope 是可以 benefit 啦。因为 central vision 它还有 preserve 的话是 OK 的。
So 那在 center vision 它有的话，我们讲去 improve 它的 field of vision 哦，对不对 ？For distance。
对，就 magnifier 的话就是看近哦，一个看远。可以。
So how to improve 它的 distant field of vision 跟 near tunnel vision，就是要 provide training 给他咯。How to do the gauging to focus far and near or using the magnifier training 啦。怎样去 calculate 它的 field of vision with reduce magnifying 那个我就不会算了。
我想问一下哦，请问一下，如果它1.04 logma 的话啦 ，according 刚才array share 啊，是 6/60 嘛？around 6/60 是吗？
对。
这样6/60也没有到很够力差啦，可以这样讲。
是啊。
Yeah, so maybe 蛮 blur，but then 是蛮 blur 是蛮 blur 啊，是啊。这是 unaided，aided 是什么？也差不多一样。telescope 可能会好一点点。没有哦，那时候我们玩 telescope 的时候，我们戴着我们自己的眼镜嘛，哎，好像是戴着自己的眼镜。哎呀，如果 blur 的 vision 拿着 telescope 会轻一点。
660。
Vicky，
你刚才讲那 telescope 吗？那天我有试了，我没有戴眼镜，因为那个 eyepiece 可以调。
如果 let's say 那个 patient 他的 vision 已经 blur 了，没有被 corrected 了，他看出来的 image 应该用 telescope 应该也是 blur 的。
会blur 啊？
除非他调咯。
会调啊
放
，IP
远一点点罢了。
哦，
因为本来 VA 都差嘛，他只是可以看更远一点的东西，他本来是可能放一个东西，他可能可以看多远一点，可是那个 vision 还是blur的，可以这样讲吗？
哦，那个 telescope 和 magnifier 其实是那个 patient 可以看到 near vision，他用那两个他都可以看到远了嘛，因为他的 distance 是很近罢了。魔鬼吧。
所以等下怎样 reply 老师的东西啊？
可以这样 reply, can reply like this because magnifier or telescope also will narrow the field of vision 嘛，肯定会嘛，是吧？Yeah, is seen nearer, so the field of vision is narrow 啦 and also the telescope also narrow the field of vision.
Mm. 你们看到这个 slide 吗？他说 distance 8啊，他们好像有试那个 telescope 嘛，它的 VA 是可以 improve 到6/12。
OK。如果用那个 regular 的 telescope 是没有 helpful 在 tunnel vision 的，但是用 reverse 的话就可以帮忙，或者一些 view 比较宽的就可以帮忙。
view 比较宽。view 比较宽就讲跟旁边那个 8 times 跟 20mm 有关系。
我search到有一种叫 field expansion prism 的。
SAG？
不是，就是我上网找。
哦。如果tunnel vision。
把它的 result 都 better 吗 ？use 那个 magnifier speed 不要 monocular telescope。
那个是 telescope。
Listen hits。在最后下面那边，你们差不多是 expect 可以去到 6/12哦。
这个 patient 差不多可以算是 tunnel vision 了吧？这个吗？这个影响呢？他的问题是，如果 patient 有是 tunnel vision，用 telescope 或 magnifier，会影响到 narrow 和 wide 的 vision field，就是会不会有帮助到 ？Let's say 他的 tunnel vision distance 就像这样，which is applicable on 这个顾客啦。这个 patient 我是这样载，他的 VA 会更好。 像 Jennifer 讲，只要用那个 extend 的，就会看到好一点。
reverse 的
reverse
读到 Alex 讲的，
可以读到。因为它 VA 有 improve 嘛 ，VA 有 improve monocularly， 再加上用 reverse， 就是随地有的reverse VA， 它应该会看得更清楚，也会看得更快。How about magnifier？
magnifier 不知道是不是那边写要用 illuminated 的是比较好。
magnifier 一定好的。
我们看回它的那个 new magnifier trial on right eye， 用了这个有灯的 illuminated stand magnifier 是 0.8/1， 它的 unaided 是 illumination
2.5 6M，
它 use on right eye， 就讲它两个眼睛看 right eye。所以可以解释一下这个 new magnifier on right eye。不是很明白这个 magnifier 用在 right eye， 就两个眼睛开啦。
它的 better 它的 better seeing eye 是在 right eye， 所以它应该是用那个 right eye 来看东西，所以它才用写在那边是 right eye。OK。然后 right eye 它用了 magnifier， 它有 improve 哦。
对，就从 2.5 或者是 both eye 1.5 1.5/1， 它变成 0.8/1 cm， 是用8倍的。它 currently 这是 unaided， currently 还用这10倍的，但是没有 test。Here VA reading speed。67.74 word per minute， 这是它的 reading speed， 在第一次啦 unaided。and 139.86， 这个也是unaided，这样是第二次的result比较好是吧？因为139，这个是怎样考？我忘了。号码比较大是比较好还是比较小比较好？word per minute。
比较大比较好吧。
看近的大是不好啊，是不是？
就是那个word per minute。我的问题是呢，
就越多吗？不是，越大就越多吗？
对，大，如果是 word per minute 的话，是越大越好。
OK， 好啦，就讲他第一次的 是67.70，比较少咯。OK，然后第二次他再来的时候就读到139.86，这个也是unaided来的嘛，所以这第二次比较好咯。但是如果我们看那个2.5M 的话，M 越大就越不好，是这样子吗 ，Alex？ Thank you。
其实你觉得要不要问下面请他怎样算哦？如果是从那个 N notation 换去 N 的，什么 formula？ 之前有教过吗？好像没有，是不是？
就是乘8呗，是吗？
乘8。
好像是有人讲过怎样乘8的，还是乘
Alex， 你是讲从 Malaysia 换去 Negeri 啊？
对对对对。
下个我想问一下 coming 的 Doctor Fu 的是 standby 的是谁啊 ？Jennifer， 第三个是谁啊？就是那个要 standby 的人是谁？那个要 standby 的人是谁？就是好像每一场要有3个人 standby 嘛，只是3个人 standby， 只是3个人。
李燕啊。
李燕，你是第3个啊？
好像是李燕。
就说是 Jennifer、Serene 和李燕啊，李燕第3个啊。OK。
Semalam mereka layan customer sampai pukul 10 lalu.
我们的 discussion 完了啊？Hello，Hello。
30完了吧？
其实这样的 case 应该是，如果是 binocular 来讲是 consider strabismus 哦。
Hi, welcome back.
Hi, we are here.
Hi.
Yeah.
What were you doing? Listening to PM's announcement, is it? We also did the same thing. Anyway, we are Malaysians. Okay. So coming back to the question, the relationship between tunnel vision, telescope and magnifier, and how that actually affecting their vision. Okay. So what answer you got? I saw, in the chat box got one explanation. Okay. Anybody wants to answer? Okay. Suddenly become quiet already.
Looking for chat box.
Okay, so yeah, I will start first. So based on my point of view and the info that I got, so basically telescope by using a tunnel vision patient, so it's very depending on how it's a conception of this telescope. So as we understand that the telescope will help us to target the far object. So there are benefits that they can expand the vision by the telescope, but only in the reverse side. Then of course the image will become smaller. So it is good for the tunnel vision to locate the objects. But there are also studies saying that the severe restricted field of view is not significant helps. So the only benefit left behind is patient doesn't need to scanning while we are using the telescope compared to the magnifier, because magnifier you're gonna restricted by the field of view, and then some more you're gonna holding your magnifier to screen. That is a little bit different here. But if you're using it in a proper way in the telescope, so when there's a disadvantage as well, because definitely the field of view will be even narrow when you're using the telescope, even with the tunnel vision compared to
Okay. Okay, just one question. So if they are okay, if let's say the visual field of the patient is already, restricted. When they view through the telescope, is it going to be more restricted or not?
Yes, it will be restricted. They actually it's magnified the visual, they call the visual text, but not the visual size, but it's not the visual field.
Mm-hmm.
So that
So
is a concept.
you think there will be a restriction?
It will become smaller because it's just like we are playing the slit lens. The bigger magnification, you are actually increasing the field size, but not the field of view. So that's very difficult for them to locate and aim a specific target unless they went through a proper training. What I mean is that aim and target is those moving objects like moving bars and all this. When they want to use the telescope to locate it, it's definitely much more harder.
Okay.
So that it's a bit of the telescope. Of course, back to the magnifier. So it's also depending on how far and how near you're holding at your magnifier. So of course, the further you hold, it will make the vision narrow. Okay, when it closer, that will definitely increase the field of view. So the benefit, as I mentioned earlier, is quite similar. It's to increase the text for the low vision. And as I mentioned, it's a field size, it's not a field of view. It's just like we enlarge the specific area, not the field of view. We can see more by the magnifying. So disadvantage that the patient need to frequent screening. As I say, they're not only turning the head, locate at the center, and then some more while they are reading the magnifier, they got the trace. It often trigger tiring and confusing. So the other thing, it's in the conclusions so balance in between the magnifying is actually depending on the visual needs and also the lifestyle. So the higher magnification would definitely decrease the low field of view. So it's the same for telescope or magnifying glasses. But there's a very interesting things that I found on the source that there is a contact lens. It calls a telescopic contact lens system. It's actually invented 1930s. But it's not very commonly used, but it's something good that can minimize that kind of restriction that we mentioned earlier in the telescope, and it will help some. Yeah, so there's a bit more from me.
Okay, good. Anybody else having some other opinion regarding this? No, it doesn't mean that you have to say yes to, what Ray has mentioned. Anybody else having a different opinion? Because I do have a different opinion. That's why I'm asking. Anybody?
Yeah, Miss Indira.
Yes.
As Ray said, tunnel vision patient, they already have a limited field. If they use telescope or magnifier, it will become even narrower. So for me, I think scanning and training is very important.
Yeah, are you walking? Are you running or something?
I'm in visual.
Oh, it's okay.
Visual boleh cakap ke?
Yalah, visual
You
boleh
concentrate
jawab
lah. Oi.
Okay, nah,
Nanti
this is
biasa
more
rapi
important
sangat risau. Oh.
Health is more important. Okay, anyway, yeah, what do you want to say?
As I remember, just I recall when Ray talked about this case, I recall your pre-record can use loose lens, high minus loose lens, so they can adjust their distance to adjust the view of field.
Okay.
For tunnel vision, and for reading, I think dome is good for this patient.
Okay, because the field of view is bigger.
Yeah.
Okay. Anybody else a different opinion than what Ray and Ben said?
For my point of view, the reverse telescope will help for the tunnel vision because it can increase the field of view. So,
okay, so that telescope. Okay, so you're talking about field expanding. Okay, my question is, if let's say the patient is having tunnel vision, use telescope, is the field of view is going to be more constricted or not? If let's say patient has tunnel vision, they use magnifier, is the field of view, if let's say they can read 4 words only, okay, at one glance, okay, because of the restriction of the field of view, how many words they will be able to see when they are using magnifier? Is it going to be lesser, going to be same? Obviously not going to be more, okay, that is definitely not. But is it going to be the same or is it going to be, lesser? That's my question.
Lesser.
For the telescope is the same, almost same, but magnifier definitely will be lesser.
So you think telescope will be the same, magnifier will be lesser, okay?
Yeah.
I think the magnifier you need to move a bit closer then it's
okay, if it's 10 magnifier anyway, you're going to be very close to the, but hand magnifier, yes, obviously you have that, ability to adjust, okay?
Yeah, if it's stand magnifier, that would be a different story. That definitely helps seeing wider, depending on the size.
Okay.
I think the telescope, the distance for far is almost the same, but the near a bit difficult. I think near will be smaller visual field for the telescope.
Okay. Now I will lead you to my answer. Okay. What is the 3 labels that you see on telescope? What is number 1? The first one, what it stands for?
Magnification.
Okay, second one?
Field of view.
Second one is diameter of the lens. Objective.
Lens power.
No. Telescope. The first one is magnification. Second one is not diopter, not field of view. Diameter of the objective lens. Third one is what is the third one in that label for telescope?
degree of the field of view.
Okay, correct. Okay, for magnifier, what is the first reading? The label. There are 3 readings also, right? The first reading is for magnifiers. When you label it, there are 3 readings that you need to label. The first one is what? Telescope. Everybody answered. Magnifier, why?
Meg,
Magnification.
Magnification. Okay.
Magnification power.
Why this magnifier di anak tiri kan? Nobody wants to open mouth. Okay, the first one is magnification. Second reading is
Diopter power.
okay, power. Okay, third one is very easy.
Illuminated or non-illuminated?
No.
No.
Number. It's a number also.
Is a number or description of the lens?
Number. There are 3
It's a
numbers.
number.
What is the last number? You all know lah. Similar to
4
telescope.
times 60 chapter
Size of
150.
size of the
Size of
Degree.
the lens.
Degree of the lens.
Yes, field of view.
Field.
Okay. So now forget about the answer that you have discussed just now. Okay. Now with the last value for both the telescope and also for the magnifier is field of view. Can you relate that and come with the answer? Whether tunnel vision patient will have a lower field of view or better field of view with the use of the telescope and magnifier. You know, right? The third reading is field of view. Based on that, can't you think of some other answers? I don't want to directly give you the answer. I want you to think.
Lower field of view.
Question again, the question that I asked before the break. Patient is having tunnel vision, using telescope, using magnifier. How does that affect the field of view of that patient? You all say that, okay, distance might be, your answers for quite mixed lah, can be better, can be worse, okay? Now, with that field of view value that is a clue to answer this question. There is a value of field of view in the telescope, and also there is a value of the field of view in the magnifier. Now think whether you can connect anything.
That is the purpose why they want to invent it in a different kind of field of view lenses, because it's increased the size of field of view. So it's actually related to the field of view lah, definitely. But we are talking about if it's telescope in the standard version, not using the reverse telescope. So ideally that will be restricted. It will become more narrow before we engage to a bigger field of view.
Okay. Almost there. Okay. Almost there. Somebody talking or someone else is talking?
So if the telescope or magnifier is written and remark the field of view there, so let's
all
say
the telescope, all the magnifiers will have that. It's not whether it's written or not. All the magnifiers and telescope will have that field of view mentioned.
So assuming I'm a tunnel vision patient, so I request to get better field of view. So the examiner might give me different field of view reading to let me try. So which one I can get better field of view? So
No.
I think
No, it doesn't work that way.
Okay.
Then I will focus
I will answer this first before you get confused. Okay. The reverse telescope that patient use as a field expander, right? It is not something that is measured based on the reading that is given. It generally works, okay? Like randomly to anybody, okay? They can just reverse their telescope and the field get expanded, okay? It's not like, oh, I have like 10 degree. No, I have to choose a telescope of 15 degrees so the field expands. No. Even if you choose a telescope with, if let's say your tunnel vision is only 10 degree, you're only left with 10 degree at center. If let's say you use a telescope with a 5 degree of field of view, when you reverse the telescope, it will still expand more than 10 degree that you see. That is not related to the reverse telescope's purpose. Don't get confused with that. Okay, when we actually ask patient to use the telescope as a field expander, okay, we don't do any calculation. If you have telescope, you just reverse it, you will have an expanded field of view only. There is no calculation involved. Okay, I hope I made that clear. So now coming back to the question, tunnel vision patient, use telescope, use magnifier, is the visual field will be more restricted or not? Okay, so now since the telescope and magnifier already give the field of view, how that influence you to have a different answer now? Pin drop silence again. Thinking, is it?
Yeah.
Today very quiet. Okay. Think.
Today brain cannot move.
Yeah,
Is
no
it we
difference.
have to?
Yeah, no
Sorry,
difference. Okay.
Yes.
Yeah. Ben, you first.
I go first. Okay. Is it before we talk about these cases, we have to focus on the patient vision field of view, the germ, how many degrees affected.
So then, when you prescribe, what do you do?
Then I will focus on the magnifier or the telescope degree, not more than that.
Not lesser than that, you mean?
And not lesser than that, yeah.
Yes, correct. This is what the answer that I want. Okay, basically, when we want to prescribe telescope to patients or magnifier to patients who are having tunnel vision, you have to pay extra attention, okay, when you are prescribing that. If let's say they need, okay, nowadays people don't use telescope, but you as an optometrist, you should know this knowledge. Okay, when you want to prescribe telescope to a patient who is having tunnel vision of 10 degree, okay, only left with 10 degree. Okay, so you want, they have like a blurry vision at distance, they want to look at something, they need telescope. When you prescribe the telescope, make sure that the field of view that is mentioned in the telescope should be, okay, similar or slightly bigger than what is the field, visual field of the patient, shouldn't be lesser. Okay, if it is lesser, right? Okay, if let's say, for example, if let's say they're looking at a board at distance, okay, they can see two words at a time. Okay, when you prescribe a telescope with a similar field of view as the patient's visual field or bigger than that, patient will still see two words. But if let's say you prescribe something that is smaller than that 5 degree, you're going to actually, make patient only see one word at a time. Although the clarity is going to be good because the image is magnified for the patient, it comes closer, but the visual field is further restricted than which is already restricted with your original vision. Got it?
So patient have to move the
Similarly,
tip more.
Good.
yes. Okay, so we, if possible, if let's say we have options, then we go for something that the visual field is similar or bigger than what the patient is having. Similarly, for near magnifiers, also the same. Okay, if let's say patient have like 10 degree, again, able to read like 4 words at a time. Okay, when you want to prescribe, magnifier to the patient, look back again at how many, what is the field of view that is actually, written on the label of the magnifier. Should be similar to what the patient's visual field is, or should be slightly bigger, so that, even though it's going to be restricted, so at least patient have that, not much, from 4 words, seeing 1 word is going to be difficult for the patient. From 4 words to 2 words or 3 words, it's still okay. Okay, we don't want them to, 1 word they see only half. That's going to be difficult for them to read. So whenever you're going to prescribe this to the patient, you have to take into the consideration of the field of view of the patient. Got it?
Got
Yes.
Got
Yes.
Yes.
Okay. Another thing is when patient is already have tunnel vision, right? Okay, the field of view is very restricted. Okay, as you know, the field of view, the visual field itself is very restricted. So when they use this magnifier, right, the purpose of prescribing the magnifier is to actually magnify the image. Okay, and obviously that when the image is actually zoomed in, as how you zoom in a picture, when you zoom in, you get the clarity. But obviously the the information at the side is going to be cut off. Okay, our concern when we are prescribing telescope or magnification is the cutoff that happens when the image is magnified for the patient through telescope and um, magnifier shouldn't affect the productivity of the patient. That means how efficiently they can read or see with the magnifier and telescope. Okay, it shouldn't affect them much. Okay, because it's already very restricted, very limited. If you further limit them, it's going to be difficult for them to use the device. So that's the concern that you have to have. If, let's say, you prescribe them with a telescope with a lower magnification, okay, but lower magnification, patient, lower magnification with a field of view of 10 degree as what the patient is having, but patient is not achieving the target they want because the magnification is not enough. Obviously, you have to increase the magnification, okay? But when you're choosing within, if let's say both A and B telescope is achieving the target, but you don't know which one to decide, okay, then you look at the field of view degree, okay, and also how patient is actually, how much patient comfortable with the two devices, okay, in terms of the number of words that they can see on the, or letters that they can see on the chart. Okay? Okay, Karan?
Yeah.
Okay. So this is another new information, okay, which we never discussed in the, telescope or magnifying, lecture. Even in the pre-recorded lecture, also I never discussed this. That's why when I saw the case, I have written this as an additional point for the discussion. Okay, because every semester students will question this lah during the clinic. How means if let's say tunnel vision, the field of view going to be restricted more or lesser? At least when you see patients, you can explain about it. Okay, yeah?
Okay.
Okay, anything else that you want to discuss about the case that we missed? The presenter or the non-presenter, anybody wants to say anything about this case before we end the session? No?
For any new invent instrument
For?
for this type of case, because I think telescope and magnifier have been heard for so many years. Any new instrument to invent to help them to visual field.
Visual field, and to expand visual field is the only three that I have explained in the, the lecture video on peripheral visual field. Okay, scanning therapy and all that. But obviously, as I mentioned, earlier, telescope is no more in trend lah. Nobody is using telescope. Okay, so telescope is definitely, not a trend, and its usage is also very limited. So definitely there is no choice options for the distance device, like let's say patient is having problem in terms of the blurriness. But for near magnifier are still relevant. Okay, there are many patients who are still using magnifiers, especially handheld magnifier. Handheld magnifier, dome magnifier, bar magnifier, VTM, all that is still in the practice. But stand magnifier is very limited already. Okay, because you have to bend down, it's not comfortable, right? So that is also out of the market. But you as an optometrist, you have to learn this. Okay, that's why we are teaching you in the syllabus. Okay, so that too. So as a replacement for that is for telescope, it's a phone camera. Okay, taking picture and zooming in to see the details. That's one. Okay, for near, it is like a magnifier app. iPads that you can, have with the magnifier app on it. So that will be helpful for the patient, which I've also recorded, I've mentioned in the pre-recorded lecture of electronic devices. You can go and check there also. Okay. So these are the, alternative options that we do have to replace, stand magnifier and also telescope mainly. Okay. Waiting.
Miss, how do you find
Jennifer,
the
wait,
bio?
wait,
Yeah.
Jennifer, you want to ask question ke or you tersilap tekan?
Ask another question about this.
Okay. You ask first because you raise up the hand for long.
Oh, just ask for about the concern of the baby. So it's how the mother is the congenital cataract, and the father also have the retinitis pigmentosa. How about the baby? Okay, any?
Okay, this one is very. Okay, the possibilities is 1/4, 25%. So we cannot, confidently or say that, oh, definitely will have, but definitely it will be carried to the next generation. But the percentage is only 25%. So 25% of possibilities to be carried. So there is no like a clear cut saying that okay, confirm mesti ada punya. Okay, Jennifer, did I answer your question?
Okay, yes. Means like the baby get the chance for like not have normal not have low vision problem, right?
Yeah,
Because
that one also
25%.
25%. All also 25%. Okay, to be this also 25%, to be normal also 25%, to be carrier only also 25%. So they are all 25%.
Any test can do for
Genetic
test.
test. Yes, genetic test can be done.
So
You
should
can
advise. Should advise.
Yes. If let's say that patient is very worried about, what's going to happen to their next generation, right? They can actually go and, do that. Certain patients, they just accept the fact, the fate, just, go on with that. Certain patients, they're very concerned about this. Okay, so for that patient, you can actually ask them to go for a genetic. So it's just a blood test, yeah. It is just a blood test. From there, they actually take the somehow they extract DNA and all that. This is what the doctor told me. I don't know. I've never gone through this. Okay, but this is the way that they do it. Then they will explain if let's say you have any family related conditions, can be anything, your kidney problem, any other problem. So that will be actually listed down in terms of the possibilities for your next generation to get. So that can be done. Okay. Okay, Ray, Ray wanted to ask question just now. We give him chance. Ray, you want to ask something just now? Yeah.
I'm asking for how do you find the bioptic? Lately, I saw there's a lot of articles, not like that. I mean, advertisement showing out the bioptics.
Yeah, even in
Is it
Insta
commonly
also.
used?
If you see, advertisement is more. But have you seen any user using it? No. Okay, so that's why I say it can be very vigorously shared, to advertise it, but the practicality is not there, as how it works for magnifier. Okay, so any devices for distance, right? Whether it's bioptic lenses or iris vision, or the one using VR and all that, right? It's highly advertised, but when you look at how many have actually purchased it and honestly actually being benefited from it, right? It's very minimal. That's why it is not widely spread as magnifier, because magnifier works. Okay, that's why many people are using it. That's why the flow of the magnifiers in the market is higher. Obviously not so high as spectacles, but it is higher compared to telescope. Telescope is almost like extinct in the practical.
Yeah, because we have no chance to prescribe that also.
I never prescribed also.
Even though the telescope we meant to use is during the concert, we want to see further. Okay, we purposely bought one.
Yes. Yes. Because it's just a
In clinical,
short-term
no
use.
lah.
Yeah, yeah. Clinical wise, even in these many years, right? Since I did my degree, I joined in 2007 until now. How many years already? Okay, I've never prescribed any. Almost 18 years, never prescribed any telescope to any of the patients. Many have asked. Okay, after explain, then they know the reality, then they don't go for it. Okay. Okay,
Yeah,
this
thank you. At least
Stephen,
know
you
the
can ask.
better understanding about this.
Yeah.
Okay, I want to ask the retinitis pigmentosa and color vision, normally the carrier are women. So if the father has retinitis pigmentosa, I think most likely the next generation wouldn't get, isn't it?
No, they can get it. Can.
Not like colorblind. Colorblind, maybe woman is carrier.
Colorblind and no, colorblind and retinitis pigmentosa is two different diseases. Retinitis pigmentosa affecting the sight vision. Color blindness is affecting center vision. So unless if let's say the patient is having retinitis pigmentosa and also color blindness, it's a double joy kind of thing lah, but double sadness lah this one. Okay, so it's not related to each other. And if let's say father has RP, kids can definitely have RP. So there is no skip in generation for this. Including television also. There is no skip in the generation when they are passing down the gene. Father has, kid can have. Mother carrier, kid can have it. Okay. Anybody else? Yes.
Yeah. Can I ask? Yeah.
Yes, Kevin.
Since the telescope is not being prescribed nowadays, I can remember, I think about 10 or 15 years ago, I still going through the low vision class. They're still introducing the telescope. So means that telescope have been like not using it for how long?
Okay. When I was student, right, when I was in 2007 to 2011, right, patients in UKM, they were still using telescope. They were prescribed. Okay. When they come to clinic, they bring their telescope. Okay, now people are not doing that because of the advancement of technology. Because at that point of 2007, we are still using the Nokia phone, that era. Okay, so there is no camera and all that. So people were depending only on telescope. So that's why, because if let's say they want to scan through anything at distance, right, they need something. Okay, once the the smartphone is introduced, right, I think around 2014, 16, 17, before COVID, it was like, people start using the smartphones. Yes, that's the time that people see that. Why do I need a telescope when I just can take picture and then zoom in? I can know what's actually in front. Why do I need an instrument that's specially made just to view that? And it's only for short term. Similarly, like the picture that you capture in the phone. That's the time that it is actually totally become, not being prescribed to any. But there are some special cases. Okay, some special cases where people are using telescope, but not in our country, but in other country, as I mentioned, like UK and US, where they can still drive, right, with the that fixed vision that is actually set by the country, so they are still using it. But in Malaysia, it's actually extinct.
Okay.
Like dinosaur already lah. No more.
Because I can remember that they can mount to the glasses, and then there's a one button on the belt there. They can press to zoom in and out.
Yeah. Yes.
Yeah. So
Okay,
that
now,
one also no more that one.
no, they do have. We do have supplier who's doing that. Yeah, we do have one supplier in Nilai. Okay, if let's say you want to test or you want to have a talk with that person, also I can actually share the contact number. She is Puan Ajila. Okay, she's from Nilai. She is actually still have that she have it in hand. Yeah. Okay, because when I gave a talk in Penang, so she came and actually, display her items. All she has like many telescope, the clip-on, all that she has in hand. So if let's say you want to have a look and learn how to actually, dispense this, you can actually contact her. I can provide you with her contact number lah. So still there.
Still there.
In supplier's hand, but whether people are prescribing or not, it's definitely a doubt lah.
Okay.
Because now after the smartphone, right? People are not into telescope anymore.
Yeah, view cam even better. Now view cam can see even clearer.
Yeah.
I think the future we can use a smartphone to expand the field of vision by zoom in the smartphone. Then
It's
the
already been using, Steven. So it's already been expanding, okay, for patients, right? So they just need to take picture. You just zoom in, or when you take picture, you can actually need to move your head shorter, a smaller steps only compared to if let's say you're using a telescope and all that, right? It's going to be more complicated. So this one is easy. You just can zoom in short distance. You can zoom whatever that you want. So you don't need to move your head much. So it's already been been used by the patients to actually expand the field.
you mean the
So in
smart glasses? Like
smart
by
glasses, smart
Facebook
glasses
one.
also are there. I have tried one smart glasses also during MAB's exhibition. Um, it is there, but the expansion, it is not up to the satisfactory level of Mila. Okay, they have come and demo that, but still, how practical is that is still a doubt for me lah. How practical it is, it's yes, it's wonderful, you can see things, but how practical it is, that is actually a matter before you prescribe to any patient. The practicality, you can be very excited to see the new stuff that they come out with, but as a clinician, right? As a clinician, you have to think whether if I prescribe this, would patient benefit from this or not? When are they going to use it, and how are they going to use it? Okay, so that all matters when before you're suggesting something to the patient. It's always exciting when you see new toys, whether the kid will play with the toy or not, before you decide to buy for your kid. Similar thing also. So before suggesting, you have to think practically how this is going to actually help the patient. That's matter.
In China now they have glasses that got AI assist that
Yeah, I
blind person,
saw.
yeah, the
After you all
person
told
can
me.
talk. They
Yeah.
can talk and describe at the front what you
Yes.
have, even the colors. Yeah.
But again, how safe it is. Anything that you give, right? It should make patient to move independently. If let's say they're going to be depending on someone still to move, right? So that is not a. But patient might like it lah, because at least even when they are sitting, also they know what's surrounding that. Okay, that might excite the patient, but whatever that you prescribe to the patient have to improve the quality of life of the patient. It's not only improving for 1 or 2 days, like kids, right? When you give them a new toy, they'll be very excited for 1 or 2 days. The third day, it will be in one corner. Similarly, with this kind of new devices, right? Yes, it is exciting for us to, to look at the advertisement, to see people are using it. People, get to know what's surrounding them for 1 or 2 days. The third day and fourth day, back to normal routine. Whether that is going to actually help them, for the rest of the day, for lifelong, then it's worth spending to buy lah. Hmm. Okay. Any more questions? No? Yes? No. Okay. If no questions, okay, thank you very much. Okay, thank you for group. Yes.
Sorry, one more question.
Yes,
The
can.
tunnel vision, what is the smallest angle of field of view degree? Smallest 10% or 5% field of view?
No, it can be 2%, 3% also, up to that level. When patient's vision is deteriorating, right? It can go up to 1%, 2% also. We do have patients who have 5% or 4%. We do have patients like that. So, and they can go blind, at one point of time. So it slowly reduced.
How many degree? 3 degree, 4 degree. What's the
Even 1 degree then become blind also got.
how you rate the severity of the tunnel vision? Because
based on Jaren screen result.
Because severe, moderate, or low, or how?
No such classification. There's no like moderate visual field loss, severe visual field loss. No, depends on the patient's complaint. Let's say it's affecting their the life so much, then it's severe. If it is not affecting, then it's moderate. So there is no cutoff point.
So we can't tell the patient you are severe tunnel vision, you are
You can demo to them. Okay, if let's say Jerem screen, okay, you can demo to them that the world is this big, but yours now is only this much.
Based
So
on
that's
the test lah.
Yes, based on the test. Okay, but whether it's severe or bad, it depends on the patient. Certain patient, I do have one patient who's actually having, in Segi only, but I forgot his name. Tunnel vision, 5 degree, both eye, vision is 6969, still driving happily. When I ask him, you go out yourself? Yes, I go anywhere. Also, I go by myself. I don't depend on people. 5 degree only, at the center. Glaucoma patient. Another patient that I have, okay, he has about, slightly bigger than this patient, okay, but his vision is 612. So that patient already stopped driving and he takes train from Mantaka to KL by himself alone, independently. Because he says that with vision 612, he still can walk around by himself. Okay, and his, field of view, of visual field is about 10 degree. But then that person is not driving, so it's very depending on the patient, how individually taking it.
How do you judge the degree of the field of view by the Jerome? You look at the Jerome chart.
Each Jerome is 5 degree, man.
Each Jerome is
5
degree.
that circle, right? One side is 5 degree. So you just tamba only lah. If let's say patient can see the second circle, then it's up to 20 degree. First circle only 10 degree, and first circle only half or smaller than that 5 degree. That's how we actually estimate that.
How about let's say the field of view, the right is more, the right is 20 degree, the left one is different degree.
Can. Tunnel vision also, anyway, the peripheral cannot be seen. How small is a tunnel vision or how big is a tunnel vision is the one that is actually explained by the degree of the visual field.
Okay.
If let's say a patient is 30 degree, another patient is 5 degree, obviously the 30 degree is having a better field of view, okay, a better visual field compared to the 5 degree one. That interpretation is enough.
Okay. So we can explain to the patient that they have how many degree of field of vision.
Yeah. We can actually tell the patient. And most of the patient, they know one. Because usually the ophthalmologist also tell them, okay, you left with 5 degree, you left with 10 degree, can. Jennifer, tunnel vision still driving? Yes, you cannot drive with tunnel vision. Already advised the patient. One patient, the second patient that I told you, right? The vision is 612, comes from Pahang one. That patient was driving when he came to my clinic the first time. Then he said that if I let go driving, right, I feel like my ego got crushed. Okay, but I told him one thing only. How if let's say you hit a baby or you hit someone on the road and that person dies because of your constriction in the visual field and also your drop in VA. Would you like to have that ego? That guilty feel for lifelong, or you want to let go your ego? Then the next time when he come to our clinic, he was taking train already. So you have been seeing her for past 2 years, 6 months once. He comes by train only. He told that's how we explain to the patient. A certain patient, they understand, certain patient, they don't.
How is the existing law that can stop this type of patient to drive on the road? Because
there's no rule. Even patient with color vision also still driving.
But other country got such rule, no? Like USA, advanced country.
I'm not sure on that lah, but Malaysia don't have. Okay, it's all about the vision and also color vision only. So it never mentioned, how much the VA has to be, the minimum VA for driving and all that. Not mentioned anywhere. Because there is no concern. Okay, why do I say no concern? If let's say, okay, like a recent case in Malaysia, right? Okay, there is a lot of accidents that is involving bus, especially the OPSI one, and then the recent lorry accident, right? After that, only people become very strict in Puspakong. when they want to Lulu scan, the license for this, lorries and bus. Okay, previously it was bit slightly loose. So if let's say there is a case where visually impaired person driving and hit someone, and something happened to that patient, that victim. Okay, then Malaysia will have a rule. So for the moment, there is no recorded report saying that this tunnel vision patients or visually impaired patient or patient with color vision problem who are driving and hit something and become a case. Until then, no action will be taken.
I think the investigations officer like police, they also wouldn't know whether they got a vision impairment or
yeah,
vision.
nobody will say it. So that's why
they are not optometrists, man. They won't investigate, isn't it? Even
yeah,
already
because
research also they won't know also.
Because the awareness is less. Okay, people won't think that it could be a vision related problem that lead to this accident. Okay, it's all about whether the patient was sleepy or not, patient was, it's about the car condition, attitude of the patient. Once accident happened, then only, they will check the background of the driver's, case in the, police cases and all that. So vision is not in the concern of the, people actually. Okay. So like our country also, we have, when we take license, we check, they check, color vision and all that. So there's no enforcement for that lah. So that enforcement can be recommended in
But color
future.
vision now for problem, the JBJ won't allow you to sit for the car license.
But people memorize, ma. That's what happened. What memorize and then go answer.
Sometimes the people they went to ophthalmology signed the letter job, then they can sit for the exam.
Yeah.
This was done in Malaysia.
So yes, Malaysia boleh, as Anping said. Why does Malaysia only check color vision when issuing non-vision? Yes. Okay, actually that enforcement is not there lah. Okay, maybe I can do a research and write that. Join masters, do that. Because I saw some news of country will check. Yes. Okay. That should be the right way lah. Okay. Check VA, check color vision, and follow the right rule. And also, whenever there is some accident happens, right? Always have to check whether the vision was a problem or not. Okay, that leads to this. Okay, and then that can be a reason for us to suggest that VA need to be checked or follow the strict law that is already created to get a license. Maybe. Sheila, thank you for giving me the idea. Maybe I'll think about it. If I can get the PDRM's case reports or accident cases, do a short study. Whenever there is accident, we check their vision. And then we see whether vision is related to, the poor VA related to the accident or not.
Yeah, so check do a study on it.
Yeah.
Then maybe government
so we will
employ
make a new policy.
police station.
Yeah, policy. Enforcement so that, people with poor VA and color vision shouldn't be given license.
I think association can do like MOC, no manpower to do that.
No lah, research anybody can do. I also can do research.
Yeah.
But then the PDRM has to agree to do this, right?
We gotta meet PDIM for lah. Talk with them.
See, like if let's say you know any big PDRM person, police,
I think the
you let me
transport
know.
ministry lah. You need to meet transport minister.
Wow, so high level. I baru think about JPJ only.
That one, he is the policy maker. You see the matai.
But you go meet the minister, right? They will ask for evidence. You show me the evidence first that, those who actually, when accident happened, whether the driver has vision problem, and you show me the proof, then I will make the law. That will be the one.
Step by step, the research need to be carried out.
Yes,
and then
you need to carry or prove that.
later we need to have a bigger spoken power, like the
Yeah.
MOC or whatever they come out with this
Correct.
statement.
Then
Miss
we
Indira.
can actually propose to MOC, say that, you see, I found this. I think you should, recommend the policy to the ministry. Then the MOC will do that.
Why other
means when
countries
we
do
read-
that? We can study the other country law, then follow their experience from there.
No, we
Then
can't do that.
Do some research here, then we can submit the research to the minister.
No, it has to be done and proved in our country that our country is having this problem. Different country, different way of, enforcement. Their enforcement way is different. Yeah, Vicky, you want to say something?
Just now you said when we meet like police or anything, someone pangkat higher, you say what we should raise to them?
Not raise. I say we can do a research. If let's say any kenalan, recommend to me. Maybe I can actually go, through them I can do this research. Whenever there is accident, I go check their VA of that, the driver who made the mistake. And if we see like, memang if let's say the VA is good, but accident is still happening, so VA is not a cause lah. So those with poor VA who are driving, they're driving more cautiously compared to those who are having good vision. We can conclude that way. So that's what I meant. If you know anybody, why?
Or is it like we should say we should I don't know what to
No,
yeah,
no.
because
I was saying that if let's say you know anyone, you introduce to me so that I can do a research use my, final year student, the upcoming student. I can do a research ma. Okay, whenever there is accident, maybe in 1 month time, okay, in Kota Damansara police station, whoever they come and report that saying they got accident, they must go through the VA chat. And then we'll get a data on that. That's what I want to say.
Is it in Malaysia we don't have any similar research like this? No,
I have to look for it. I don't think so. I've never read any. Because if God, surely MOC will publicize it. So far tak ada. Maybe I have to.
Mostly to ask the PDRM get the culprit, the driver, to check their eye in KKM optometrist hospital or what. Then
that's not easy. PDRM, they don't want to help you one. Because it's none of their business. They're not getting anything. So it's a big project. You do small one first. Do in one balai first. Then you carry out to a big one. Once you get the data, then you show to people, there is existing data showing that this is what happening. Then carry out a bigger one. Then once carry out, already find the data and then show to the MOC. Okay, MOC should know that, oh, this is actually a problem. Then MOC will actually speak to the ministry. So go step by step.
If you go to the MOC file, I think about 18 years ago, I think MAPO and MOC have the memorandums to the Ministry of Transport, direct to the minister in transport minister. Yeah, nothing been done because there's no statistics. There's no
without statistic, no move will be taken.
Yeah, even those the government also don't have any base for you to do some research.
Yeah.
Yeah. So
it's not easy.
Yeah.
Involving government, it's not easy. We private, we can
because
just go on and do
that
it.
time got so many road accident, the lorry driver. So there is a memorandum written, but no action also. Yeah.
Without statistical data, right? Nobody will lie on you. You have to have the data. Yes.
I think
the
the
statistical data
very important.
Also, they have no time to do data for you.
Yeah, we have to do it. If let's say you have the intention of, to prove something, we do it, we show, and then we see how we can actually, make a, policy for that.
Recruitment now at all. Later the journal, a lot at all one. Come, recruiting.
Okay, I do the research, then you all help me your area. I will ask, the policeman to send to your shop.
No
your
one
check
study
and give me
master.
the
No one study master.
The study master you just come with a policy, yeah. Okay, we got carried away with this driving license and all that already.
Okay.
Okay.
Thank you.
Anyway, it's a nice discussion. Let me see what I can do from my side on this. Okay, thank you very much for today's presentation for Group A. Well presented. We will see. We'll have one more session next week, right? Every week one session anyway. So next week is Group B, yeah? Okay. So thank you so much. Please bring something interesting. You can actually, okay, other than the case in the clinic, you also can get some case studies from journal articles also to discuss. Okay, get some nice journal article, and then we can also discuss that in the presentation. So it's not restricted only to the clinical one, the one that we have in our clinic, but journal articles case study also is okay to be discussed. At least we can get something very new that we don't see in the clinic. Okay? Okay, thank you. Bye-bye.
Thank you. Bye-bye.
Thank you. Thank you.
Okay. Bye-bye.
Bye-bye.
Bye.
Bye bye.